Well, good afternoon, everyone. As everyone's settling in here, grabbing your lunch, we're going to get things started with some administrative things. My name is Omar Khan. Welcome back to the Innovative Discovery Series. First of all, thank you to Dr. Bill Weintraub and Sarah Faye Heckler for directing and coordinating this series respectively and for allowing us the time to be with you today. Before I start, I want you to review some housekeeping items. So for online participants, those of you on the phone or on the computer, please keep your mics muted unless asking a question. And we should have some time for questions at the end. Please use the chat feature in BlueJeans if you have technical questions. Our previous presentations are all available at the ACCEL website, which is DE-CTR.org. Please make sure you sign in. There's no CME for this talk, but please make sure you sign in the back. Next up, we have the State of Immunization, Understanding Law, Policy, and Resistance by John Culhane of Widener on November 6th. And there's a couple of others after that as well. Sarah Faye can get you on the list for that. Please RSVP so we can get enough food and drink for the next session as well. Any questions, please email Sarah Faye Heckler. If you have, she's in the back. Sarah Faye, wave. Perfect.
Everyone knows her.
Everyone knows her. Great. And we have some new attendees today, which is fantastic. So I'm going to get us started. We are just enormously privileged. I'm going to introduce our speakers and our talk. We're just so privileged to have with us some luminaries in global public health here. Dr. Shiva Goudar is from India. He's from the JN Medical College of KLE University. Longtime collaborator. Dr. Derman is going to say a little bit more about our joint work. And he has flown all the way here for a variety of meetings, including this one. And we're going to go on shortly to another one, which Dr. Derman will talk about. Dr. Richard Derman needs no introduction. For those of you new to the system, he is the chair of obstetrics and gynecology at Christiana Care Health System, professor of OB and Gyne at Jefferson Medical College, and one of the co-principal investigators of the Global Network for Women's and Children's Health Research, which has been continuously funded by the NIH for the last 12 years. Okay. Alrighty. So I wanted to preface our talk by talking about the Delaware Health Sciences Alliance, and this will become clear to you in just a minute as we talk about our research collaborations. And the Health Sciences Alliance, as you know, is composed of Christiana Care, Thomas Jefferson, Moores, and the University of Delaware. And we work together on a variety of education, research, and service projects. And they include all the ones that you see there, many of which are also ACCEL CTR priorities, such as cancer, rehab, and maternal and child health. We have a particular interest in global health education and research, and in support of which we have some terrific events every year. This is just a neuron map of all the work that we do together. Not coincidentally, global health is in the middle, but we focus on a lot of different areas: community engagement, healthcare delivery, research, clinical science, and so forth. So our work really is to coordinate much of the terrific initiatives happening in each individual institution. Global health is one of them. We have our we have an active website here which you can link to. The presentation will be online. Our annual Global Health Symposium concluded about 2 weeks ago, and we do national presentations such as the one coming up, which you will hear about shortly. And we support DHSA-wide partnerships for all 4 institutions who participate in. At Christiana Care, global health has really been an emphasis for research and education. You'll hear about research in a second, but I wanted to emphasize the education piece. We actually have global health residency tracks in 5 residencies here, and we have several global health elective sites for research and education around the world, in India, Bangladesh, and the UK. And we partner with ACCEL and with departments and with service lines to make this work happen. I see at least a couple of global health track residents here today, so thank you for coming. We have our flagship Global Health Conference, as I mentioned. We also have a keynote at the Holloway Infectious Disease Conference, who is traditionally the global health speaker. Last year we had Barry Wilson. The year before that was Tom Quinn, and the year before that was Ian Henderson. So we've really attracted significant firepower to Christiana in the area of global health. I'm going to turn it over to Dr. Derman now for an overview, and then he's going to talk about, I guess, some research projects, Richard, and then will take over.
A little bit. All right. So as Dr. Khan, first, let me just say that we have an unwritten rule between the two of us. And that unwritten rule is never say no. So I can say that both of us have been guilty of saying, would you do the following in a couple of days? And the answer from Dr. Khan has has always been sure. And I have felt the need to follow suit by saying yes. And so today, this is sort of, I didn't even realize what format we were going to be using, but we're going to be presenting this in a similar way at APHA coming up. So this is sort of a rehearsal. We've never actually done this presentation, and we're going to try it out on you guys. And we know we're among friends, and we'd love some feedback and critique and input, and of course, questions as we go forward. So let's do this. You know, this is a different map than I usually show, because usually I show a map really where we do our work in Belgaum here. Much of our work is done here. But this time you notice I've included Dhaka and Bangladesh. So this is sort of our South Asian collaborative with Dr. Khan, and we really see a sort of a joint venture coming up. In fact, we do have a grant into Fogarty with Dr. Khan being the PI on bioethics, and we hope to be scored. And wouldn't it be wonderful if that gets approved? And that relates to the schools of public health, both in Belgaum and in Dhaka. So a rather unique approach to getting a South Indian bioethics grant. And thank you, Jerry, for your support on that. We appreciate it. So this all started with the NICHD Global Network. It's supposed to create infrastructure, and that's what we're most proud of. It's supposed to create capacity. It goes back to 2001. And it was just a little short blurb saying that NICHD is going to get involved in the international health business. And for those of us who worked with NIH, we said, gee, that's really terrific. Why is that happening? Well, it turned out that the Gates Foundation had given them some money to get their interest flowing. This is beyond Fogarty. It's a big institute of NIH. And so together with our colleagues in India and with my fellow, we sat down and we wrote that first grant on postpartum hemorrhage. And Shiva will mention a little more about it. I won't be focusing on that today. But that sort of put us on the map because that now has become standard of care. The outcomes were very, very positive for us in the use of misoprostol. But I think the reason I point this out is that really we haven't looked back since we started doing that. And so there have been 12 sites that have involved in the global network, and some have faded out, never got they couldn't recompete, or they recompeted and they were not successful. So we have been successful from the very beginning, 3 5-year cycles. And these are the countries that we're now working on. 2 sites in India, 1 in Pakistan, Guatemala, the Democratic Republic of the Congo, Zambia, and Kenya. So there are 7 sites that are now funded, and there are 7 institutions in the United States that are the partner sites. And those include the University of Alabama, University of Colorado, we here at Christiana, Columbia University, University of Indiana, Harvard, and Chapel Hill, as well as the Data Management Center at Research Triangle. And in fact, the RTI people are here now because we're working on our new grant that we're going to talk about moving forward in a little bit. So how do we know we've been successful? Well, from a single grant, we have now 14 funded sources over the last 12 years. And this is there are 2 things to be proud about if you're in the research arena. When you're building capacity and infrastructure, you want to know that you're not relying on a single base of funding. Because frankly, it's like an advertising agency relying on a single client. You could be dead in the water. So we're very proud that from this initial grant, WHO is funded as the Harvard School of Public Health, the Academy of Pediatrics, the Gates Foundation, and many others, and that continues. That's a reflection of the good work that these people do in the field. I don't have a slide, but out of this network in the last 12 years has come 207 index peer-reviewed publications. A very, very significant number of publications. So what did we work in? Initially postpartum hemorrhage. We're now doing we've just completed and published work in emergency obstetrics. We're part of a network doing work in hypertensive diseases of pregnancy. We just met in Vancouver on that. Maternal nutrition, there's a big ongoing study starting preconceptually. Prevention and treatment of birth asphyxia. essential newborn care, growth and development, and environmental health. So the leading causes of maternal and neonatal mortality and morbidity is the focus. But notice that I have underlined prevention of preterm birth, because that is what we're going to be focusing on, and that is the focus of our next major NIH study, actually two studies, one not NIH funded that I'll mention to you after Dr. Goudar does his presentation. But this is where our focus is going to be, and that's what I want to focus on today. So how do we define that? It's delivery prior to 37 and 0 days, 37 weeks. And we know now, even in the U.S., when I trained, we said, gee, if you got somebody to 37 weeks, everything's fine. Now we know that every day that we carry people closer to 40 weeks, it's less time in the NICU. And so March of Dimes has been really good on that. There are 13 million preterm births that occur in the world. 11 million are in Asia and Africa. So hence the reason we do our work there. That's why people say, why do you work there? There's an enormous cost, and obviously there are already limited resources. So there's no way to effectively address the outcomes in many of these countries. So the darker it is, the worse it is. I have a slide like this that you may have seen on obesity around the world. This is a slide on preterm birth. You can see that Asia is pretty bad, and you can see parts of Africa are pretty bad. But I want to point your attention to the United States. Not so good, not so good. So I will share a slide with you on that as well. So these are the countries that are involved, and these are the WHO preterm birth rates for those countries. And notice, with the exception of Guatemala, which is pretty good, they hover around 13%, and the United States is about 12%. So in fact, if we look at the next slide, well, first we'll talk about India. India leads all countries in both maternal and neonatal mortality. So you talk about a living laboratory. We always talk about Delaware as a living laboratory. My goodness. In India, 19% of all the maternal deaths in the world, fortunately down not only 56,000 a year only. And in terms of childhood deaths, under 5, 2.8 million of them. Preterm birth is responsible for 780,000 of those. Massive number. Obviously, preterm birth in the U.S. and everywhere else is the leading cause of cerebral palsy and developmental disabilities. Enormous angst to families, just a very, very terrible situation. And there are large geographical and regional differences all across the world, and lots of disparities as it works out. And we'll talk more. But I do want to show you this Delaware slide. This is South Asia, and this is Oceania and Southeastern Asia. We're higher even than sub-Saharan Africa in terms of our preterm birth rate. So I will show you in the next slide that we've made some headway, and we've brought this down about 1 percentage point in the state, and a little bit like that in the United States overall. But we can win the Nobel Prize if we can go ahead and be able to go ahead and find the reason and the ultimate cure for preterm birth. So it's a big deal. So the cost of preterm birth in the U.S. alone, this is direct cost, is about $26 billion in 2005 dollars. That was the last 2006. The last that I saw. It says 16.9, so overall it's 26 billion. That was the estimate, of which 17 billion is direct cost. This is an enormous amount of money, and probably the highest thing linked to pregnancy by Medicaid in terms of their expenditure, and I think the third leading cause of dollars spent in any healthcare issue that we take care of in the United States. So we've done pretty well here in Christiana. And of course, we've been able to bring preterm birth rates down, have better outcomes beyond 32 weeks to 32 to 36 weeks. Haven't done as well in the rest of the developing world. But this is where we run into trouble. When mothers deliver babies at 28, 29, 30 weeks, we haven't been able to make any dent there. I see Dr. Locke in the audience, and I think you would agree with those babies at 15, 16, 1,700 grams, we have a tough time. And this is the number of days in the NICU in the United States. And you can see, obviously, that the earlier the delivery, the number of days in the NICU goes up, the costs go up, morbidity goes up, and the long-term complications go up. So it's a real challenge for us. Most of the developing world doesn't have this situation. This doesn't look so great, but this is very, very good. And you have to go to only a few tertiary care hospitals in the places that we work to find that kind of equipment at that kind of detail to young babies. It just isn't available. So the babies either die or they really have very, very bad outcomes, which in some cases may be worse. So can we predict preterm birth? Most cases we can predict it. Just like postpartum hemorrhage, in most cases we can predict it. But we do know that there are certain things that increase the risk of preterm birth, and we actually have some ways to mitigate that. So a history of prior preterm birth, that's a predictor. A short cervix, that's a predictor. Premature rupture of membranes, hypertension, smoking, infection, drugs of abuse, diabetes, obesity. This all raises the limit, and we can sort of screen out who might be at high risk, and this sort of helps us go ahead and design clinical trials. So that's a direction that we are taking. And what we've done in the United States, we've been using injectable progesterone in women who've had a prior preterm birth, vaginal progesterone for those who have a short cervix, acerclage. Now there's a new pessary with some good data to go ahead and move these cervix up. So we have ways that we can do that. But these are costly interventions. So the secret in the developing world is how do we do a low-cost, safe intervention that can impact a large number of people? In other words, what's the public health mechanism that we can move forward? I'm going to share two studies with you afterwards, but I'm going to go ahead and turn it over to Dr. Goudar, give you the bulk of the presentation, and then I'll come back and share the last two studies that we're working on.
Well, good afternoon, and it's a pleasure to be here among a number of friends. This is what my 12th or 15th visit to Delaware, starting from 2009. So, what I'm presenting this afternoon is some of the work that we have been doing as part of the NICHD Global Network that Dr. Derman mentioned, and as he also mentioned, this is sort of a dress rehearsal for APHA, which Dr. Khan has been kind enough to extend an invitation to share some of our work to in that meeting. At the outset, I bring greetings to you all from my institution back home in India in JN Medical College. We are the third oldest private medical school in the country, run by Trust KLE, which is actually in its centenary year now. And JNMC itself is a 52-year-old institution. You have probably seen these numbers being read out on many fora. The mortality and morbidity burden, both in terms of maternal deaths and newborn deaths, and in terms of the sheer proportion and numbers, India has a long way to go in terms of addressing these mortality goals. I mean, reduction in mortality goals. MGDs have come and gone, and now we are talking about SGDs, but the progress to achieving those MGDs is much slower than what we had hoped for. And part of the reason is, in many situations, we probably have some solutions to reducing mortality, but the question is, how do we take them to scale in a larger community health setting? And much of the work that we have been doing as part of the global network is really testing interventions or taking interventions to the community to impact the larger public health outcomes. So we started this journey 15 years ago, basically as a result of the collaboration between Gates and NICHD with three distinct missions. Number one, and that's really the key, to develop sustainable research infrastructure in the global network sites by partnering the foreign institutions or the international institutions with an US academic institution. So each one of our foreign sites has a US collaborator that we work with. But the model is somewhat different from the typical grants. The foreign institution, the US partner, and NICHD actually work together in developing scientific protocols. So it's not something that's like a top-down approach, but rather more a collaborative, cooperative agreement among all the three key partners in bringing forward research ideas which are relevant to our settings. When the network started, we basically had individual sites come up with what they thought as key ideas. So for example, we had sites in South America looking at interventions for cleft lip, cleft palate, antioxidants for preeclampsia. Then the site in Guatemala started out with complementary feeding studies. Then, there's a sort of a diverse portfolio, including some efforts at controlling maternal and newborn sepsis, chlorhexidine wash, or probiotics for newborn sepsis. Our site and the site in Tibet looked at interventions for postpartum hemorrhage, and we looked at misoprostol as an option for settings where cold chain maintenance is a challenge, because many of the oxytocin products, at least the label says that they should be stored at 2 to 8 degrees centigrade. At least most of the companies do have that special storage requirement for oxytocin, and therefore we have been looking at alternatives to oxytocin, which can be used in settings where maintenance of cold chain is a real challenge. Of course, that trial proved that misoprostol can be safely used and has very good efficacy in terms of reducing PPH rates by almost 50%. Got into now it's in the WHO list of essential medicines, in the UN commodities list, and more than 26 countries have actually registered misoprostol for prevention of PPH now. But the problem with use of misoprostol is that it does have some adverse effects. Shivering and hyperpyrexia are the two commonly reported side effects of the drug. And therefore, we still continue to work on looking at alternative approaches. Can we minimize the dosing and still not lose the efficacy of the intervention? So we just finished a study with Genuity looking at universal prophylaxis versus early treatment or secondary prevention. It is only administer the drug if the women bleed beyond 350 ml, when they can really get into a problem. We are also currently working with WHO on a heat-stable product that has come out from Ferring, carbetocin, room temperature stable product. So we are right now in the process of getting regulatory approvals. It's again a multi-center trial sponsored by WHO. And hopefully we should be able to initiate the trial in the new year. So that's some of the work that we have done as a sort of a follow-up from our initial study study on misoprostol for PPH. But as the network moved to its second phase, the second cycle of funding, the strategic decision was, rather than do individual site studies, why not go for common protocols which can be implemented across the entire network. First breath, the newborn resuscitation protocol was our first common protocol that was implemented in the 7 sites that were part of the network at that time. And this was the first real adaptation of the NRP program to a community setting, taking the resuscitation training down to the lowest cadre, the TBAs. Of course, subsequently the AAP came up with the HBB module. We were part of that field validation of that curriculum. And of course, now HBB is being rolled out globally by AID. And part of the requirement for the first breath trial was to have a pregnancy tracking system so that we get the outcomes at the cluster level or the community or population level. And that's how the Maternal and Newborn Health Registry came into existence, wherein from 2008 onwards, in our study areas, we essentially capture every pregnancy and its outcomes through 42 days postpartum. And as of now, for the entire network, we have over 500,000 pregnancies, with Belgaum alone contributing nearly 150,000 pregnancies to that data set. Now, what the registry permits is not only a mechanism for collecting data for our cluster RCTs, but actually look at trends over time in these populations in terms of maternal and newborn mortality as well as morbidity. And since the last 2 years, we're also collecting data on maternal near miss, which is what the WHO is now trying to focus on. As the mortality rates come down, the focus is now shifting to the near miss cases. So I'll share with you some trends over time in the 2 Indian sites. We are down in the southwest corner of India, and Belgaum and Nagpur, the other Indian site in central India. Now, between the 2 sites in the 4 years from 2010 to 2013, we have more than 100,000 pregnancies in the registry. And we have a very good tracking system wherein there's very little loss to follow-up of the pregnant women. So we are able to capture almost 100% of the outcomes of those who are enrolled into the registry. So we looked at how well the ministry initiative of promoting facility births and skilled birth attendance is working. So there's a big push for facility births by providing a cash incentive to pregnant women if they deliver at a facility. And the cash incentive is also greater if they do end up actually having a C-section. So there is a real push by the ministry. And what we have seen is by 2013, in both the sites, almost 100% of the deliveries were occurring in facilities. Now, this may not sound as a real big deal to this audience. If we go back a couple of years, I mean, we are not showing that data here, but if we look at the data from 2006, 2007, only 30% of the births were in facilities. So there is a dramatic change, which is being driven by this cash incentive scheme of the ministry. And corollary to the facility births is that skilled birth attendants is also increasing. Earlier, we had almost 2/3 of the deliveries being conducted by the IEs or the traditional birth attendants, and now nurses or the auxiliary nurse midwives or physicians, they are conducting the deliveries. So there is a big shift. Has that translated in reduction in mortality is a big question, and at least the answer appears to be perhaps no. There's only a very modest reduction in mortality. And if we look at the breakup, much of the reduction is actually in terms of the stillbirths. There's really not much change in neonatal mortality. So we looked at what's driving this, and the pattern is similar in both the sites, Belgaum as well as in Nagpur. So what we are seeing is actually increase in C-section rate because of the facility births, which is perhaps contributing to the reduction in stillbirths. But in terms of reducing neonatal mortality, there is really a need for additional interventions, strengthening of facility-based care and follow-up care once the women go home. So there's still a lot that needs to be done if we are really to get a handle on the perinatal mortality. And a whole bunch of publications came out actually as a supplement in reproductive health in June, looking at various aspects and trends over time in the registry. So those who are interested can look up this particular supplement. A recent trial that we have just completed last year was published and is beginning to make some major ripples around the world is the antenatal corticosteroid trial. I don't know how many of you are familiar with this study. Again, an intervention that has been around for decades, but with very low uptake in the developing world. So we started thinking about why or what are the barriers for scaling up this particular intervention, which at that time was thought to have a great potential in reducing mortality from preterm low birth weight babies. So we conducted a cluster RCT in the 6 global network countries, 7 sites. Almost 100,000 women were enrolled to the trial. The intervention comprised of 3 essential things: a community level identification of women at high risk for preterm birth based on symptoms, then administration of the corticosteroid in those who are expected or suspected to deliver preterm, and then following up to capture the outcomes. So in terms of the primary goal of increasing the coverage, I think all the sites did very well. But within 18 months, the rate of utilization went up from 10 to 45%. So one would really think that at least that part of the intervention worked. But did it translate into reduction in mortality? And this is where the real surprise was. When we looked at all births included in the trial, there appeared to be no benefit or harm, neutral. But when we looked at, the smaller babies, when we looked at all babies, then we found that there was actually a harm, an increase in mortality in those who got the steroid but ended up delivering at term. Something which was unanticipated, unexpected. And then we started looking at what may be contributing to this increase in mortality in the bigger babies, which were expected to deliver preterm, but actually ended up delivering term. There are only some signals to perhaps increased maternal and newborn sepsis that may be contributing to this increase in mortality in the bigger babies. Because we used the registry as the data collection mechanism, we don't have that sensitive data to really tease out what went wrong or why we found this unexpected result. But there's only some signals which need perhaps further exploration in more advanced settings. But clearly, what we think happened is, number one, there was sort of over-treatment. So the triggers that we used to identify the women who have the potential of delivering preterm were perhaps not the best indicators. So we need more precision, more sensitivity in the tools that we use to identify the women who have the risk of delivering preterm. And also, in most of these settings, there's really not much infrastructure available to take care of the small babies. So you may have immediate survival, but in terms of ensuring long-term survival, you need better care, better facilities. So a standalone intervention around delivery will perhaps not be enough in these settings. So we need a larger, more comprehensive approach than just a single targeted intervention. We also looked at the registry in terms of how well the nutritional status of the women is, and again, what we find is almost 90% of the women have anemia. It's only a question of how severe the anemia is, but almost the entire population appears anemic. They are also grossly underweight, and short-statured. So we did an assessment of the food security in the preconception population. And what we found is that almost 15% of the population is having some degree of food insecurity. And being a country which is still agrarian economy based on the monsoon, one bad monsoon can change this picture dramatically overnight. So that's one aspect. Number two, we also looked at their dietary consumption. We did a 24-hour dietary recall and then a repeat recall after 2 weeks. And what we find is not only is there a gross energy deficiency, but in fact a severe micronutrient deficiency. You look at iron, zinc, the rates of deficiency are alarming. They are consuming less than 50% of the recommended dietary allowances. So it's in that context that there is one ongoing study where, rather than the traditional interventions which usually begin in the first trimester onwards, they're now trying to target the preconception period, because they're not going to develop this kind of deficiency only after they conceive. They're carrying that deficiency into their pregnancy. So perhaps the best window of opportunity to intervene would be prior to the conception. So we are right now doing a 3-arm study looking at using a micronutrient supplement initiated in the preconception period compared to the same intervention being initiated in the first trimester. And of course, we have a control arm which gets the current standard of care. We are just about completing enrollment. We should have the results by the middle or end of next year. So we are now in the third cycle of the global network funding, and right now working on initiating this major study. Dr. Derman will talk more in detail about this study later in the subsequent portion. But right now, we have moved from postpartum hemorrhage to newborn resuscitation now to preterm birth. So that's sort of the agenda that has evolved for the global network in the last 15 years. We had a major celebration earlier this year in June, where we presented what we think are significant accomplishments over the last 15 years to the global public health effort. So on that note, I must thank all of the funding agencies which have supported this body of work. Of course, Dr. Derman has been a great leader, mentor for the past 15 years. Been a great friendship as well. We hope to continue the good work in the coming years. So once again, thank you for having me this afternoon.
Thank you, my good friend. It's a good thing I like Indian food, because if not, I'd be in big trouble after all of this time. Actually, India is now sort of my second home. I'm going to take only the last few minutes to talk about two studies that have recently been funded. Actually, one we're almost complete with. And so these are recently funded studies relating to reducing preterm birth. First relates to a short course of an oral antibiotic, Clindamycin, in the second trimester of pregnancy after organogenesis has already occurred, among women with an increased vaginal pH. This is important because we're learning more about the microbiome and the biome in the vagina and the endocervix. And when it turns out that when you get a pH of over 5, then there really is an opportunity for an ecological imbalance, which may lend itself to an inflammatory response. And so that's one thing that we're working on. And then you heard Dr. Goudar, and this is with Thrasher Foundation funding, a single-site study, and I'll tell you just briefly about it. And the other one is going to be among all of the 7 sites. We got the highest score in the network for bringing a proposal forward. So this is the one that NIH has decided to concentrate on over the next 3 years. So a little bit about the pathways of preterm birth. Like with many other diseases, heart disease, I looked at Bill, maybe cancer, maybe others, there seems to be a common pathway. And that common pathway seems to be inflammation, where that inflammation is secondary to infection, stress, an abruption or a separation of the placenta from the body of the uterine wall, or stretching because of increased fluid. It seems to go ahead and play out in the same manner. And this cartoon actually shows you what happens with cytokines and prostaglandins that get produced when any of these inflammatory responses take place. And two things happen. You either get cervical changes where the cervix gets soft and shortened, or you start getting uterine contractions. And in both cases, the women end up going into labor, and we end up with a tiny baby. So the published antibiotic trials have really been a mixed bag. If one goes to the Cochrane Review, it's not impressive. And if you look at using clindamycin ointment, for example, directly into the vagina, hasn't worked. Erythromycin, which is broad spectrum, metronidazole, or in combination, minimal changes. Some small change, but minimal changes. However, 2 studies, when we go through the whole review, have shown that if you deal with bacterial vaginosis specifically by looking at those women with an elevated vaginal pH and treating them and going after changing the ecosystem of the environment, we may be able to make a difference. One of those 2 studies was a study done at our site, and it's even larger than a pilot study, and it was just accepted for publication. So stay tuned on that one. So this is a single-site trial. This is a significant number, 1,726 women, plus the randomized placebo-controlled trial, treatment of all pregnant women who have an increased vaginal pH. So how many is that? Between 30 and 40% of every woman in that population. So you can see that if you can affect the change, it can have dramatic impact on the outcomes. And what we did is we went ahead and we treated them only for 5 days, between 13 and 20 weeks of gestation. But here's the key. Total cost about $2 per treated patient. Now that's in a small study. We can get that cost down by more than half if this becomes large. So where do we stand now with the trial? This is the outcome, reducing preterm birth by 30%. Secondary outcomes are mortality, birth weight, stillbirth, and obviously a careful monitoring of side effects. Are we seeing any C. diff? Are we seeing anything else that's a safety signal? We have not up to now, which is really good. Really short-term use. So the recruitment is completed. We've done it. The last delivery and 42-day follow-up is going to occur by April of this year. If successful, we can avert in India 300,000 newborn deaths and 150,000 stillbirths. That's fairly significant. So obviously we're all excited to see what this looks like when we move forward. The next study is the aspirin study. I like the acronym that's been developed around it. Notice that it says nulliparous. This is the first time that we've looked at this. We had an external advisory board that said don't go preconceptually, but try to get patients in as early as you can. Now everybody uses aspirin. Everybody uses baby aspirin, but nobody uses it in the first trimester of pregnancy. So that's a big deal. We're using it for an unapproved indication. So what we're doing is all pregnant nulliparous patients who present in the first trimester, and for the first time we're using ultrasound to confirm dating. We don't run into the problems that we had in the ACT trial. This is really important. And this is an identical placebo. This is not cluster N. This is individually randomized. All 7 sites, 12,000 women over 3 years. So big trial, fairly costly. These are the target enrollments, and I only point out that our site in Belgaum is going to have, as is often the case, the largest projected enrollment of all of those sites. The study rationale suggests that the greatest potential of impact is when you can get in there early before the decidual response occurs and before the inflammatory response occurs. And if we can do that, aspirin, we know, blocks platelet aggregation. We know it blocks pro-inflammatory cytokines. It inhibits certain prostaglandins. So we think maybe we can break that cycle. That would be great. So we want to prevent that cascade from occurring early in the game. We're going to follow these women by giving them daily baby aspirin or placebo through 36 weeks of pregnancy. So the study outcome is to reduce the rate of preterm birth by 20%. That's an enormous number if we can do that with a very simple intervention. And we're looking at all of the other usual suspects. We have the potential to reduce preterm birth by 4 million a year on a global basis. And this is thanks to my friend David Paul. He lent me this slide. This is what we want to avoid. If we can avoid this, we will have made great strides. So thank you for your attention, and we'll be glad to answer any questions you might have. Questions coming still.
So I'll ask a couple. First of all, it's great. It's wonderful work, and congratulations on all you've done. I'll ask one simple one. What's the rationale for the use of aspirin? I may have missed it. The other is, tell us a little bit about the logistic problems of randomizing people and following, gathering data and analyzing data when you're doing it in the developing world. In the cardiovascular world, we do this too, but it's quite a challenge.
Well, I'm going to let Shiva answer the second question. I'll answer the first question. Actually, the use of aspirin has just been approved by the U.S. Preventive Task Force in all women who've had a prior preterm birth with very good outcomes, showing a significant reduction in a second preterm birth. And about 1/3 of all preterm births are due to preeclamptic women. And so about 1/3 of the preterm births are due to preeclampsia. So there's already a rationale for doing it. And what we said is you can block that cascade. We seem to have less preeclampsia, and we don't understand all of the mechanisms.
So I think it's a prostaglandin.
It's a prostaglandin thromboxane relationship through the COX-mediated system. That's the way we seem to believe it plays out. and we'll know. But we already have good data on prevention of repeat preeclampsia, and it's already now recommended in the U.S. as standard of care. Hasn't been implemented all over, but this just came out this year from the U.S. Preventive Services Task Force. From the other point of view, having follow-up rates of 99.6% has gotten the attention of the global community. So I'll turn it over to Dr. Goudar.
Yeah, I mean, basically the Maternal Newborn Health Registry is sort of the soul of what we do. As part of the registry, and in fact as preparation for the registry, we do an annual household survey of the entire study population. We enroll all women who are in their reproductive age, 15 to 49. We go back to them every year to look at, number one, the family status, the conception status, as well as whether they undergo any sterilization or. So to the point now, we have very good ability, in fact, to predict who are the women who are likely to conceive in the next 1 year. So we basically set sort of targets of what is the expected number of pregnancies every year in the communities that we work. And the actual enrollment is almost close to projected number. And we have got better every year with doing this. And having that platform really permits us to not only enroll every pregnancy, but in fact enroll them early and track them through 42 days postpartum. In fact, almost 70% of our enrollment are less than. That's really how the registry is working. We are getting better every year.
How do you get that wonderful follow-up at 42 days?
Once they are in the system, we don't lose any. The challenge is to get them into the system. So all our effort is to make sure that we don't miss counting any pregnancy. So that's where we are really putting all the emphasis on. Once they are in the system, we do everything possible to go back and.
2 weeks ago, we had a talk from a colleague in Bangladesh who talked about high follow-up rates, how that attracted some questions from the international community, and the response was similar. The first demographic surveillance system in the world on a large scale was set up in Bangladesh in 1960, and they essentially took it. And so there's benefits of working in developing countries, which have generally low rates of out-migration and in-migration in controlled rural areas, and even in urban slums. The trouble is in the lower middle class, which tends to be quite mobile. Yeah. But in many other populations, actually, it's not a mobile population. So I think you're seeing some of the benefits of that. Dr. Locke, I think.
You have this great network of community health workers. You empower women in these communities, actually, and
we basically
infrastructure.
We are not created an artificial structure for the research. We have integrated the program as part of the ministry infrastructure. We work with the ministry staff, train them, we give them some additional incentives, additional data collection activities. But it's all embedded within the system.
And Dr. Locke has been there, so he's seen it firsthand.
Yeah, actually, one of the things that was interesting was the empowerment of these women, because they were talking about a study, and these people from the community were saying, well, if you believe this study will work, why do you have a placebo arm? They would not back down on the issue of going through these things. And so that community buy-in, I think, is at the community level by community members, gives a certain level of credence and follow-up and trust in doing this type of research.
Whenever we initiate any study, there's a lot of community engagement activity which goes on. There's a lot of community buy-in.
Any additional questions or comments?
Yeah, I'm just curious, and I'm so ignorant in this field. Did you see any relationship with the age of the woman and preterm birth? And I'm thinking more about all the deficit, the micronutrient deficit that you find, and the nutritional deficits that you find.
Yeah, I mean, again, we are looking at parity, age at conception, interpregnancy interval. I mean, a number of those things are published in that supplement in June. The trend, especially in South Asia, including Pakistan, is the marriages are early, and the tendency is to complete the family as early as possible. Now the parity is going down. We don't, especially in India, we don't see the grand multiples anymore. The average parity is 2.3 now. It used to be much higher earlier. So the family size is getting smaller, and the pregnancy interval still remains short. Very little uptake of spacing methods. They try to have 2 or 3 children at most and then go for sterilization. By 21, 22, the family is complete. By the time the woman is 21, 22.
So I think it's worth me commenting during the days when I lived in India.
Yeah, so that probably contributes to that massive deficiency. Before she recovers from the previous pregnancy, she is pregnant again.
You're right. Both extremes of age as well as the inter-pregnancy interval play out on our risk factors for preterm birth. But I was going to just make an observation. I was a Peace Corps doc in India a long time ago. And there the average number of children when I was there, or pregnancies, was between 6 and 7. And the reason for that is there's no Social Security, or very little now, and the only way to assure income was to go ahead and have a male baby that would survive. And if they thought about a 40 or 50% mortality rate and 50% being girls, you can just imagine how many children you needed to have to assure that you had some security in older age. That has changed, and if you pick up the New York Times today, you will see that China has just announced a change in its policy from 1 child to 2 children. I think economic development factors are really pushing that. Interesting news.
Richard, could you just add a postscript to the very interesting study that you all actually revealed last year at APHA, which was the ACT trial, which peer review discussed huge implications. Has it changed practice? Because corticosteroids for preterm birth is just such a accepted.
I'm not sure about practice, but as far as policy is concerned, WHO and Gates were almost on the verge of making a big rollout, but now they do provide a caution that it may increase the risk of sepsis, and so they don't advise the use of corticosteroids routinely unless we have the ability to identify the right target population. And it has come with the rider.
And almost have a tertiary care center that you can take care of these children. There's no question that corticosteroids has been a major breakthrough saving lives in the developed world. There's nothing like it, in fact. And I think Dr. Locke is shaking his head. So we were shocked because we thought this is really an implementation dissemination study, which ended up being an efficacy study, not the way we had planned it, and put everybody on hold. And we believe that Gates will fund yet another study. There may be some IRB issues. Another study to go ahead and see if this is, in fact, our findings are really confirmed. Are they real? So we have to wait and see. But it was pretty exciting. Lancet picked it up immediately. So thank you, guys.
Thank you very much. Thank you.